Hello, everyone. We'll give everyone some time to pop on here. Welcome. Okay, Katie, thank you. Good afternoon, everyone. We'll give everyone a little bit of time to pop in here. Good afternoon, everyone. We'll give everyone just a couple more minutes to hop on here. Katie, if you don't mind telling me when everyone's admitted. Okay, well, good afternoon, everyone. And welcome to Bright View's very first criminal justice forum here in Kentucky. My name is Nicole Stinson, and I'm the Community Outreach Manager in Nicholasville, Kentucky. And I'm going to be your host for today's presentation. I see we have a large number of individuals from many different organizations with us here today. We'd like to thank all of you for taking time out of your busy schedule to participate with us, and we're happy you're here. Our goal is to continue to build relationships so that moving forward, we can work together to further strengthen each of our communities. If you don't mind, please put your name and contact info in the chat box for anyone who would like to connect and for a follow-up. I hope you find this hour informative and conducive to having an open dialogue. Slide 2, please. On our call today, we have a variety of topics that we're going to share with you. We've set time aside at the end of this presentation for open dialogue, and we encourage your participation. Please, as you think of a question or need clarification or just want to reiterate something you've heard, I would like for you to enter it in the chat so that I can be sure to take note of it. We will be sure to address any questions at the end of this presentation. We are also recording this session, so you may choose to leave your camera on. You're more than welcome to turn it off. It's completely up to you. But if you could please mute your mics, that'll keep any background noise from interfering. I would like to give special thanks today to Dr. Sean Ryan. Dr. Ryan is our founder and Chief Medical Officer of Brightview. Another special thanks to Dr. Nav Kane, who is Brightview's Chief Clinical Officer, and Nate Pelletier, who is the Vice President of Development Initiatives for Brightview. Thank you all for your support and for sharing your passion and expertise with us today. So without further ado, I will turn it over to Dr. Sean Ryan.
Thank you very much. So I think it's interesting to start this first criminal justice forum off in Kentucky just by making sure that folks that are attending this forum know that I'm born and raised in Lexington, Kentucky, went to medical school at the University of Kentucky, and had actually never moved out of Kentucky even one time, with the exception of living in Japan when I was younger as an exchange student. We moved to Cincinnati to go to residency to start my emergency medicine program. And at the time, my wife simply could not bear moving across the river into Ohio. So here we are in Northern Kentucky, where I'm sitting right now in my office. I was, one of the Brightview founders, and I'll tell you a little bit more about our story in just a second. But it started because of my experience as an emergency physician, and as I described, I did that training at the University of Cincinnati, where I also did my MBA. The reason for starting the organization, and it's hard to believe we're at the size and scope and influence that we are now, but the reason for starting the organization was very simple. I was in the emergency department, like many folks over the past couple of decades, watching drug seeking and opioid pill use mount substantially, and then watched it transition into the heroin epidemic, which was what I think really started to catch people's attention on the devastation that was occurring. And then, of course, it's transitioned into fentanyl and many other things now. But working in the emergency setting, as well as being a hospital administrator for Mercy Health, it was quite apparent that there was little to no readily accessible, high-quality treatment for this issue, which was killing so many of our community members. And that was unacceptable to me as an emergency physician, where we had wonderful stroke care and cardiac care and pulmonary care. And so everything else that I was trained in, we knew exactly what to do. And I think, especially at the University of Cincinnati, we did a phenomenal job of everything related to emergencies. And I guess I'll say, we also weren't treating the substance use disorder and opioid overdoses as an emergency, which of course was ridiculous because the patients were dying or had CPR, died, and then ran out the door after we told them we didn't have any help for them. So we started with a simple mission of high quality evidence-based care that was actually accessible. And here we are today talking to you all about our growing network in Kentucky and what we do to interact with one of our most important partners in the field, which is the criminal justice system. Dr. Kane.
Thanks, Dr. Ryan. I don't have all the same claims to fame in Kentucky as Dr. Ryan does. I have some. I've lived in the Commonwealth for most of my adult life and did my postdoc at UK as well. and we happened to win the national championship when I was there, so that's something, right? It was something. I'm very much excited at this opportunity today and very humbled by the fact that several dozen people have made time out of their day to join us. So I have a history of working in acute healthcare, as Dr. Ryan did, working in inpatient psychiatry and also in the emergency room for psychiatric services, but also have worked with the justice system in the past as clinical director at a residential facility where the entire patient population was adjudicated to treatment. So I have a long history of working with judges and with probation. And so very much looking forward to this discussion, because I think what you'll hear from us is that, yes, we're very proud of the services that we offer, but ultimately that accessibility and effectiveness can't be nearly as effective as we seek to be without strong partnerships with other stakeholders, and specifically the justice system and obviously other healthcare providers and that kind of thing. But when it comes to our relationship with the justice system, there's a lot of nuance to that, to how sometimes you have to operate and some of the requirements that you have in order to fulfill your obligations to the community and to the people that we're mutually responsible for. And so very much looking forward to this discussion to say, how do we work together in the most effective way? And as you guys think of questions, feel free to throw them into the chat. We received some ahead of time, but looking forward to some dialogue at the end today as well. I'll throw it over to Nate.
Thanks, Dr. Kang. I guess in the spirit of identifying where we're from, I can say I'm from the east side, being the state of Maine. A loyalist here, wearing my New England Patriots field here. But I will say I am a huge Wildcats fan, at least Northwestern, because that's where I got my my master's degree. So I'm 0-2 in Ohio and Kentucky, I can tell. But really, really pleased to be working in Kentucky, having Brightview there in the short term. Where I've been leading a lot of the criminal justice work. Just been so pleased to see the level of engagement and look forward to the questions today. So I'm Nate Pelletier, Vice President of Development Initiatives. What does that mean? My real focus is, as Brightview is expanding and moving into new areas where our services are desperately needed. It's also important to really engage at the community level and understand the needs of the community, our partners, and of the different patient types. And as both Dr. Ryan and Kang had mentioned, the criminal justice market and just the industry and the need to collaborate is probably our most important customer to make sure that we're co-treating and managing those patients. So for that reason, I was asked to look into how we can improve and optimize and really make sure that we're providing a high level of service to all of you that are in it, which is also a high level of service to all of our patients who happen to be criminal justice involved. So I've been leading that and look forward to talking a bit about that and also taking your questions as well when that time comes. Thank you much. Back to you, Nicole. Or over to Dr. Ryan. So.
I'm not sure if maybe Nicole's on mute, but I'll take it. So our commitment is primarily to our patients, and that's to deliver a comprehensive outpatient addiction treatment model that you can see here on the right, simplified into 3 components, which are medical, psychological, and social. We do follow probably somewhat maniacally the clinical research and best practices and constantly read those things, myself and our multiple other medical providers, many of which who are board certified in addiction like I am. And so we do try to stay on top of that and even participate in cutting edge research in regards to new pharmaceutical products, new devices that can actually use for things like withdrawal. And we participate in almost all of those research programs. Most importantly, we deliver high quality addiction treatment on demand, which is probably the most important thing, is those 2 components, that you have the right model and then it's readily accessible. It's a little bit complicated to say you got to catch people exactly right when they're ready to seek help, but you want to catch them there also, I guess is the best way to put it. And so when I started the concept of a 24/7 hotline to get an appointment the same day or next day in a multidisciplinary practice such as ours was unheard of pretty much around the country, unfortunately. And that's what we've built and what we see to be a standard of care. We also have a commitment to the community. We do a lot of work with the different community entities. Addiction, unfortunately, in the opioid crisis, most specifically, has been a community issue. It's devastated community workforce, as much as anything ever has, devastated multiple families in multiple degrees. And so it really is a community issue. And that's why we spend the time like this today to talk about what we're doing for our patients and coordinate care for those folks, I think better than many other diseases I've worked with in the past. Part of my past life, I was the chair of quality and patient safety for Mercy Health in a certain area. What we did was a lot of care coordination for patients coming in and out of the hospital. And that's very important because the lack of care coordination is where people really get hurt, things get dropped, and care is not optimized. So we really do try. And in this particular issue or setting and disease state, criminal justice is a really strong partnership that we try to engage with. And I did fail to mention, I've spent some significant time doing jail-based healthcare and working for a company that does this type of work here throughout Ohio and around the country, specifically because I knew that you cannot necessarily kind of disentangle patients and their criminal justice issues when they have substance use disorder. I'll finish with something you're going to hear us say repeatedly, which is the ease of access and treatment on demand has to be defined, and it has to be, what's necessary. And you'll, as partners, folks that work in the field, you will run across folks that say, "Oh, we'll see them tomorrow." You got to ask what that means. We have a 24/7 hotline, as I mentioned. That we also have a lot of folks that are in recovery answering those phones, which is I think a good quality for obvious reasons. And then we have medical providers on site and ready to see patients when they come in and they're in acute withdrawal or whatever might be wrong with them in order to manage those issues. So, 24/7 access needs to be the things I'm describing and needs to be readily available as I've reviewed. And it's important that those who are referring patients into programs understand what that really means. Next slide, please. I'm going to talk a little bit about the continuum of care here. And I'll use a couple of stats, but I'll try to simplify what you see, including the SAMHSA research top line there that talks about only 20% of patients require inpatient care. So there's two 20% statistics that you'll hear us talk about, or 1 in 5. So only about 1 in 5 patients actually needs inpatient care. We don't do that at Brightview for a couple of specific reasons. That doesn't mean no one needs it. So it's a very interesting situation in the field today where the insurance companies don't want to pay for any inpatient care generally. And most people think that everyone needs inpatient care, and neither one of those things is true. The good news is there's actually scientific tools called ASM criteria and a few others that help us to determine what level of care a patient needs. At Brightview, we do the two on the left, outpatient and intensive outpatient. And the reason we chose those is because we knew we could help the most people, the most humans, so the other 4 out of 5 in that level of care, which everyone needs anyways. I think that's an important point as well here that you can see on bullet point 2. Even if a patient does need inpatient, so 1 out of 5 people needs that inpatient or residential level of care, they still are going to need inpatient and outpatient eventually, because those short-term inpatient, residential, and then discharge and kind of alumni follow-up or other terms that you hear, they don't work. Dr. Kang and I have done a lot of research, kind of generally in the field as well as intentionally with different providers. And we'll ask them things like, well, what happens after the 30 days? How are you sure they're not drinking in the next 30 to 60, 90 days? And their answers are generally, well, we called them and asked them. That is not okay. That is not sufficient. That is not actual follow-up and making sure that the patient is doing good in a long-term recovery. And so everybody is going to kind of slide down this scale eventually if they do need to start an inpatient. And we really hope to connect with other community providers who do residential and inpatient, because that is an important part of the spectrum and of the continuum of care that needs to be delivered to many patients. So now that I've talked a little bit about that, I do want to remind folks, 1 out of 5 is still 1 out of 5. It's still a lot of people that need that level of care to be provided. So we hope to partner with folks in whatever setting to make this continuum a thing in all communities. One quick point before I finish this slide. A lot of folks believe in detox or detoxification or ambulatory withdrawal management. There's a lot of terms. Detox alone is dangerous, especially for opioids. Period. End of story. Somebody goes to a 5-day detox and they have no long-term recovery plan that includes treatment ongoing. That will not work. And unfortunately, we've known this for a long time. At this point, it's been almost 20 years since a journal called The Lancet published how dangerous detox was for opioid use disorder by itself. And so we do ambulatory withdrawal management or detoxification in our centers for a vast majority of patients, and it works fine, especially for opioids. But there are some people who need inpatient detox. There are some people that need, especially for alcohol use disorder, some inpatient detox is quite dangerous. And so the point of this whole slide is that this is a pretty complicated disease state that requires coordination of care and a continuum for patients to have access to. And that any one little piece of it is not the right way to go about it. We understand that this continuum does not exist in every community, especially rural areas where my family's from in Kentucky. I guarantee it's not there. And so we're just hoping to collaborate and build and educate people on what is necessary and hopefully is coming to fruition in many communities. Next slide. I'm going to talk just for a minute about our medical best practices. You've heard me say we have lots of years of experience, so probably hundreds of years of collective experience in addiction medicine amongst our medical providers, and we're very proud of that. Several folks like myself have gone from one career to the next so emergency medicine to addiction medicine. Some of us still do both, or OBGYN or internal medicine, neurology, different things. And we're very happy to have that cohort of medical professionals who have a lot of training. You will run across practices or treatment programs that have little to no medical involvement, or someone who basically is not well trained in the disease state, and that's suboptimal to say the least. Dr. King will remember when we started years ago collaborating. One of the other physicians who worked on the topic with us asked me, what's the bar? What's the bottom? How do you know what a quality program is at the baseline? And I said, well, if you call them and ask them to speak to, or if they have a medical professional available, and the answer is no, you have a problem right off the bat. And so that is why we so intensely focus on our medical best practices, because the evidence, the research, the literature, the publications are all there and have been there for decades. I was fortunate enough to participate in 2016 in the Surgeon General's report, both the writing of and the delivery of that. And it took us, well, not us, the group, but the country hadn't seen a report like this for decades, unfortunately, because nobody was paying enough attention. So the good news is that Surgeon General, who I believe is now the new Surgeon General again, Dr. Vivek Murthy, had the insight to say, we really need to put out a comprehensive national report on what people should be doing for substance use disorder, and that includes alcohol and opioid use disorder, et cetera. Now, surprisingly, the data they reviewed, and it was very well done, showed the things here by the checks. If you use the appropriate medications, so the medical component of the treatment, psychological and social being the other two, if you use the right medications, it will reduce substance use and relapse and overdose and associated criminal behavior and infectious disease and return patients to healthy, functional life. You couldn't write a better story for what you'd like to see our patients do. And so if you haven't read that, that's, it's a pretty long report. The executive summary is fairly good, but I was very happy to see, and again, that was 5 years now since that's come out. I was very happy to see something of that level, and that's not been the only thing, come out and kind of sustain the perspective that medications are a part of addiction treatment. The medications that we use are the three on the bottom here: methadone, buprenorphine, and naltrexone. We use some others, what we call off-label. That means the physician's or the medical provider's judgment to treat different use disorders. These three in particular are the FDA-approved medications for opioid use disorder specifically. What's most important about that, again, is that the evidence, the multiple studies and big studies mashed together called a meta-analysis, have shown there is really no debate. Medications have to be a part of a patient's treatment plan for opioid use disorder. If there is not at least the offer, of course, we can't force people against their will to do these things, but if there is not at least the offer to have a review of these medication options to a patient who has opioid use disorder, that is malpractice. Period, end of story. It's not up for debate. Hasn't been for a long time, but the evidence over the past decade has really kind of anchored that in. To talk about the specific medications and doses for just a second, I'll go back to what I was reviewing in regards to our medical professionals. Our medical team is required by our Hippocratic Oath, which we have to take to be physicians and other medical providers, to provide the best care possible in our knowledge base without outside influence. That is what we're required to do. We're also required to operate that way because of the medical, legal, and liability issues related to not doing a good job. So as an example, if I were to treat a person with a diabetic ketoacidosis or a kind of insulin coma in the emergency department, if I were to give them lemon juice because I thought it worked and it didn't and they died, I am liable for that. I've violated both my oath, as in knowing better, as well as the medical legal standards. And so these medications are the medical legal standard for opioid use disorder, and the dosing and the duration and all the things that surround that are very complicated, and they have to be determined by the medical team. I'll finish with the fact that it's also important that they get it timely. So why we work on so many programs related to collaborating with emergency medicine departments and hospitals and skilled nursing facilities is because if patients are given a plan where they're going to get their withdrawal management medications, often things like buprenorphine, in some 2 to 4 to 10 week period, that is not sufficient. It's very dangerous. And so we try extraordinarily hard to have very few hours between when the patient shows up to see us and if they're in withdrawal. Their medication accessibility is critical. I have personally seen patients walk out the door, unfortunately, because they were in withdrawal and we couldn't get, this is historical, couldn't get their medications approved by their insurance company in time. We've gone through so many hurdles over the past several years to move those kind of things out of the way. Most of the states have moved them now. So we can promise that in almost every setting, we will get the appropriate medical care for the patient in a timely fashion. I'm going to turn it over to my colleague now, Dr. King.
Thanks, Dr. Ryan. So to complement Dr. Ryan's frame around our medical best practices, I'll talk about our clinical program. So I've got several slides, not just related to the services that we offer, but then also as it pertains to outcomes, because most people like to ask us, rightfully so, is all of this effective, right? So we'll talk through a little bit of that, and then I'll hand it over to Nate. So our clinical team, I think, is equally robust. There's more people on the clinical team than on the medical team. So I can say we have thousands of years of collective experience in treating patients with substance use disorder and also their co-occurring mental health disorders as well. And so from a very concrete standpoint, like what services do we offer? Individual counseling, group therapy, targeted case management, which we actually have a separate slide on, so I'll emphasize that more here in a second. Peer support services as well. We really like to integrate family into the treatment program if we can, knowing that that's not always the easiest thing to do, especially at the beginning of treatment, knowing that oftentimes patients' relationships can be disrupted when they are coming to us for help. But we really do look to bring the family in when it's appropriate and accessible to do so. So I think our team is quite proud of the nature of the services that we provide, but also the level of service. So the years of experience is one piece of it. It's also informed by the fact that 90% of our counselors have a master's degree, and each of our sites has an independently licensed master's degree clinical supervisor. That's always been the standard at Brightview, and that's certainly been part of the dynamic as we have entered the Commonwealth of Kentucky. And so our team is quite robustly staffed. In other words, we have multiple counselors, typically 3 or 4 targeted case managers at each site, and at least 1 peer support specialist at each site that provides individual services and also does peer support group as well as a very unique service. So, for us, we really like to meet the comprehensive psychological and social needs of the patient. Again, we've got a separate slide on targeted case management that I'll touch on. But from a philosophy standpoint, how do we approach treatment? How do we approach our patients? We very much practice with what we call a harm reductionist, non-punitive approach. And I think that's very important for our partners in the justice system to understand. How do we collaborate on that? It means that we have a very unique opportunity on how we approach the patient or the person at the center of the intervention that you all are providing and the intervention that we're providing. So for us, as Dr. Ryan alluded to earlier, we apply many of the same standards in addiction medicine that I think all of us would collectively expect to see in every other area of healthcare, right? And so we don't operate in a punitive stance in other areas of healthcare. If I went to a primary care provider for diabetes care management and I was struggling to make the lifestyle changes that they have prescribed, diet, exercise, that kind of thing, they wouldn't fire me from treatment. They wouldn't call my blood dirty if my hemoglobin A1C was elevated. They wouldn't talk to me that way. They wouldn't treat me that way. We wouldn't expect that. If one of our loved ones was talked to that way or treated that way in a family medicine setting, I think all of us would be appalled. And so we apply that same kind of logic in addiction treatment, that we should treat folks with dignity and respect. We should approach patients with patience and treat them with the same type of grace that I think many of us would hope to be treated with when we're going through a change process. Because in the end, what we believe is that people with substance use disorder are people, right? And so universally, we tend to be ambivalent about change, and we, can make progress. We can have backslides. We can have periods of remission and relapse in our disease process, and the same logic can apply in this space, right? We are very clear with patients, though, on if they want to achieve the outcomes that they state when they make their treatment plan with us, that there's a level of engagement that's needed for that. And many of the talking points on the slide allude to how we recommend and strongly encourage and are quite diligent in pursuing patients and ensuring that they're meeting the level of clinical dosing, as we call it, that we think that they need, whether that's enough hours of group therapy and time with an individual counselor and that kind of thing. And I think patients respond very well to that non-punitive approach. I think many times people are surprised that we operate that way, given the history in the field. But ultimately, collaborative relationship with the patient is much easier to deliver care through than an adversarial relationship, and that's what we like to lift up. Next slide, please. So to talk a little bit about targeted case management, a relatively unique service, and I think one that we do very well at Brightview. Again, each of our centers has 3 or 4 targeted case managers, and they're able to work with patients right from the beginning. So on the first day of treatment, a patient will see a medical provider, as Dr. Ryan referenced earlier. They'll see a counselor to do their assessment. We also ensure that a targeted case manager sees that patient to do a case management assessment to assess for their social determinants of health, knowing just how large of the change process can be influenced by addressing those factors in a comprehensive way. I mean, when you step back and just think of it practically, if someone doesn't have a place to go tonight, if they don't have a way to get back to the center for a future appointment as soon as tomorrow, if they don't have food to eat, if they have some of those very real concerns going on, it can be really tough to engage in treatment even for a week. And so we know that we have to work on those things in the short term, but then also start to work with folks on building a resume, getting into a GED program if that's what they need, getting closed for a job interview, and the necessary skills and practice to navigate that process effectively. So we really target employment as part of our overall goals with patients as well. And so very much look at individualizing treatment, not just from a psychotherapy and counseling standpoint, but also from this case management, wraparound social services kind of perspective as well. And the targeted case manager, specifically if you're a probation officer or if you're a judge, anyone representing a court, or if you're a CPS, if you're looking for information on how a patient's doing in treatment, we have a release of information in place and all of those communication pathways are there. The TCM is typically the person who you're connecting with. That's the person who owns that relationship with you and can provide you with a predictable cadence of reporting and predictable content of reporting, which Nate will talk to here in a couple of minutes as well. Next slide, please. So a quick reference on Casey's Law. Just want to make folks aware that we are able to provide assessments for Casey's Law. Our centers are staffed appropriately with folks who meet the qualifications that are necessary, and we have the workflow built into the background as well, so that we can collaborate with the patient's family as part of that initiation of treatment and provide them with the clarity that they would need in terms of level of care determination and what our recommendations would be. Next slide. So a reference on our outcomes. There's several layers to this, and I'm not going to read the slide to you all, but essentially what we have done is look back in time using what you can call a natural observation study type of design. We look back at over 10,000 Brightview patients and their engagement with us over a long period of time, over multiple years, longitudinally. And how effective are we was the core question we're trying to answer. Right now, that question for us manifests in a number of different ways. We think of ourselves, as I think you all are starting to appreciate, as a comprehensive service provider offering medical, psychological, and social intervention for patients with substance use disorder. And if we're offering a comprehensive intervention, we should look at a comprehensive way of assessing the impact of that. So yes, we measure patient satisfaction, but we shouldn't just stop there. And I think there's a history in this field of stopping at asking the patient if they're satisfied, right? And so if you go to a residential facility on the beach somewhere, are you satisfied with the spa that you got to have access to, or the horseback riding that you did? Yeah, you could be satisfied with that, but does that help you with your SUD or your recovery process? Probably not. So what we look to assess is use of substances, obviously, right? And also risk and protective factors for relapse, which I think most folks can appreciate. But then we go much further than that. Are people continuing to use the emergency room or the hospital for medical reasons or for psychiatric reasons? And I think most folks can appreciate, to some of our earlier commentary that set up today's discussion, when folks are using the emergency room for overdose, that there's a game of roulette that's going on there that is really not safe for folks to engage in. And we want to limit that interaction. We want to stabilize folks from an SUD and a medical and psychiatric standpoint. But going beyond that, are folks depressed? Are they anxious? How are they sleeping at night? Again, employment, justice system engagement, getting arrested, spending time in jail as opposed to spending time at home with family. What we find is that each of these domains transforms significantly for patients. When I say significantly, I mean statistically significantly for any data nerds, if we have any on the line. We're talking p-values with 14 zeros, that kind of thing. So tremendously strong relationships between engaging in the Brightview program and the outcomes that patients experience. From a multidimensional standpoint, we really see that patients' lives transform in every way that we can measure. We have verified this data, not just using our own assessment of our patients, but also with some of our largest payers and external data sources as well, multiple external data sources at this point that really verifies this narrative around engagement with the Brightview program. We've also then been able to take the idea of, okay, those patients who have done really well, those patients who have done best, like the upper quintile of patients, what type of roadmap did they engage with us on, right? So in the first month of treatment, second month of treatment, third month, et cetera, what was the nature of their engagement with us? What dosing were we able to offer them clinically and medically? And having that insight lets us inform patients of that and really infuse them with a sense of hope that, hey, if you do the things that we're recommending here, you can get to these outcomes. And if these are the outcomes you're looking for, let's start working on that journey together, which is, I think, a very exciting thing to be able to offer folks hope. Next slide, please. And a quick reference on virtual care. I'll talk about that really quick, but really want to reference the online scheduling piece more so than anything else before handing over to Nate. So hard to talk about anything nowadays without some reference to technology and telehealth and the use of platforms like Zoom, which we're on right now. And so for us, navigating the pandemic really wasn't about figuring out how the technology works. We've been doing telehealth at Brightview for a couple of years pre-pandemic. And so instead for us, what Dr. Ryan's focus, my focus has been, is ensuring that our providers have a sense of self-efficacy and reaching patients in this modality. You know, obviously it's different to establish a therapeutic rapport with patients when we're doing it this way than when we're doing it in person. And so a necessary skill set to build that oftentimes wasn't a core part of training in school and that kind of thing for old folks such as us who graduated 10, 15 years ago. So I think the exciting piece has been how patients have responded. We have, again, we're data nerds over here. We look at our services and slice them every way that we can. And we do not see a variation in terms of engagement from patients or outcomes if they engage in telehealth versus in-person care. What we obviously see is an increase in accessibility, right? Not everybody can make it to the center all the time, and telehealth can be very helpful, whether you're in an urban environment or if you're in a rural setting. Getting to a center may not be physically possible for a variety of different reasons. Now, again, broadband access and minutes on a cell phone and all these kinds of things are their own limiting factors. But the addition of virtual care, just as another modality through which we can connect with patients, does augment access. So all of that being said, vast majority of our services still happen in person. 85+% of the services that we offer continue to happen inside of a brick and mortar Brightview. what we understand is that having that 15% or having the option to access services this way is really a life-saving link for a lot of people. Quick note then on the online scheduling piece that I want to emphasize. When I was in the hospital, when Dr. Ryan and I started working together several years ago on just trying to change how things were done in this space, when I was in the hospital, most addiction treatment providers would require you to get the patient on the phone before they'd make an appointment. Patient had to pass some kind of motivation test before they would give them an appointment. We've got to do away with those kinds of barriers, right? Just like Dr. Ryan talked about the time factor, we don't have limitations when it comes to insurance as well. We've also just got to make it so that other people can schedule for patients as well, right? So if you're a probation officer or a social worker, if you're a care coordinator, discharge planner, whatever, right? Anywhere that you are, if you have someone in front of you who needs an addiction treatment appointment, my EMT friends just love this, right? That you've got this person who needs an appointment for addiction treatment, you can walk away from that interaction. If you're a judge, if you're a probation officer, you've got the person in front of you, this probationer needs to go somewhere, they can walk away from that interaction with the appointment in hand because you scheduled them online. Obviously, you can call our 24/7 call center. Someone will answer the phone in less than a minute and get that done as well. But a lot of folks like me don't like to talk to customer service on the phone. And so the idea of doing it online, you can do it on behalf of someone. And you can also complete the release of information digitally online as well. Can't be done wrong. It won't let you submit it unless it's done properly and it's signed by DocuSign. And what's really great about that is that if you send a patient to us using that process, we know to expect them. And so when I talk about us treating folks with dignity and respect, sometimes it just simply starts with looking them in the eye when they walk in the door, knowing their name, being genuinely curious about them and how they're doing. And the idea of someone being scheduled for an addiction treatment appointment, showing up at that center and us expecting them. Oh, hey, we were waiting for you. Glad that you came in today. For a new patient, that can be a pretty new experience for them. Plus, if you're a probation officer, you know exactly when they're supposed to go, where they're supposed to go, and the release of information is already done as well, so that obviously we could do it on our end when the patient arrives, but you already know that it's done, and you know that we can share information with you. So it really creates a nice feel around our communication pathways. And Nate will talk more about that as we go to the next slide. So we use technology in a lot of different ways, but just want to emphasize that piece, because for me, when I was in the hospital, that idea of scheduling for someone else was such a big transformation that Brightview began to offer. I'll kick it over to Nate on the next slide.
Thanks, Dr. Kang. And yeah, I second all of this. I've had the great privilege of working with Dr. Ryan and Kang prior to coming to Brightview and seeing the progress that they're not only making, in the hospital systems, but also the partnerships in the community, because I was actually on that community side. I ran a large residential and outpatient center called the Joseph House, and it was primarily for veterans. And, we were ones that were looking to adapt and to see that kind of progress happen in Ohio, or in Hamilton County, expanded Ohio. And I think applying that model and, culture and belief system is going to be incredibly beneficial in Kentucky. And we're just excited to be there. And, again, part of this, and the main reason, other than to, making sure you understand our philosophy and how we're engaging and how we work, but is to understand how we really engage on the criminal justice front. So everything that we do really, even with our partnerships or our programs or everything, is to look to continuously improve. So when I was asked about almost a year and a half ago to take a look at this, it was really based off the idea that we realized, one, we had a lot of patients that were coming from the criminal justice system. Not all of them were referred, a lot of them were involved. And it certainly, the relationship we had was not seamless. We didn't have a great understanding of the need, and it reflected that in some of our feedback. So we took that to heart and authentically and altruistically looked to really improve it. So what I set out to do, kind of fast forwarding, is to figure out what is the real barrier or the opportunity, and how do we classify that, because there are 1,000 different things that we can do. After doing some surveys of our team and those who are experienced in the space, and then all of the folks in the community. Yes, at this point, this was in Ohio, we really came down to two general themes. There are clusters that are around, information sharing, and getting that and having that information be informative in a way that it meets the needs of what probation, parole, or a judge needs to make. How do they need to make a decision, and the data and the information to support that, as well as the frequency of when that information needs to be available. So, which was a real barrier, particularly because what we found is that more often than not, we were reacting to requests. And from the company level, we didn't have a standard way to respond. So credit to all of our sites, they created their own. But it made it difficult for us to figure out across all of the RightView locations, how well are we doing? So if we've got 20 plus different ways of doing it. So what we really look to do is figure out, okay, we know information and getting the right information and getting it out on the right time, op-tempo, is really a driver to managing this relationship. How do we scale that and create a system that is applied and used at all of our sites? So that is really what we went out to do. And what we found is that we had to figure out what that op-tempo really was. We were good on the information side. That was easy. We adapted our form, and it's, how we use that and information we get. And we continuously adapt that, and we'll adapt it for all of you in Kentucky if there's different things that you need. But really figuring out, well, how do we create a process to get the information out on a time frame that's not reactive to requests, but proactive? So by doing that, what we are looking to do is to make sure that we are getting the information out so that all of you in the probation, parole, or the courts, you don't need to request it. If a patient is at BrightView, you're going to get information, when you're going to get it. So there isn't this lead time often factored into it. And it also helps our sites, because if our sites have a busy day and they don't know that, or can't plan for what may be a surge of requests for reports, and usually last minute, and there's a lot of stress involved, it really throws off the quality of the service that we're providing just at the site. So if they're able to plan and integrate this in, and we can also do where it's proactive versus reactive, then we're both actually creating a meaningful process on both ends, and ultimately the patient benefits from it as well. Long story short, we found that people are either sending reports weekly, biweekly, or monthly. And the center of gravity, and I think around the mean, was that if we could get reports out biweekly, that it was meeting the needs more often than not of all of our providers. So we built a system that was based off of every 2 weeks, reports would go out from all of our sites to all of those patients, all of those partners, that required the reporting. Now, the disclaimer is we know that sometimes there's different programs, Child Protective Services, others, or court state mandated type programs that require either a different or a higher level of engagement. And we will certainly adapt to those. It's really important for us. It's the reason why we have an outreach team to know that, so we can make those decisions. But again, more often than not, our biweekly process has been really effective in Ohio. And from engaging many of you already in Kentucky, it seems that it will work as well. Again, we'll make exceptions where it's needed. So on that, we also looked at a key piece of this was, well, how do we actually know when someone's criminal justice involved? So we only knew at BrightView in Ohio when someone was referred to us, because we're able to, in our system, see that the source is whatever court or whatever probation or county, and we know that patient's involved. But like I said before, what's to say that a patient isn't involved, that's coming from the ED or another provider or just walking in? So we needed to make sure to have a mechanism to account for all of those folks to ensure that we are, initiating the reporting cycle. So long story short, we looked at it and we say, okay, we've got folks that are referred to us, folks that we can identify and will let us know on day one when we're building their treatment plan. And then unfortunately, sometimes people won't let us know until later. But we will catch it as we update their treatment plan, because we put a series of questions to ask the patient if they're involved. Or sometimes even more unfortunate, a patient gets involved in the system while they're at BrightView. The bottom line is that we have a mechanism to ensure that we can find all patients that are needed. Now, to my second bullet here it's all based off of the release of information. So we really make that, Dr. Kang has been a huge champion in making that a clinical engagement and intervention. Sometimes not all patients want to sign it. They feel like it's kind of they're scared or they don't have that information. But what we do on your behalf and the patients is make sure that they understand that that level of trust is important. And we're going to do everything we can to represent the patient when they're down and when they're succeeding. And to know that we both all of you on the criminal justice side and as a treatment ultimately want the patient to succeed. But when we don't share the information, it already creates a barrier. So we really spend a lot of time when we identify a patient and they don't have an ROI in place to make sure that happens. Now, it's a very binary situation. If a patient doesn't want to sign an ROI, there's just nothing we can do about it. But I will kind of wink at you and say, if you have a patient at Brightview and you hear from us, we cannot confirm or deny a patient is with us. We have to by law say that, but you can know in the background, we are doing everything we can to get that patient engaged, but ultimately it's the patient's choice. Lastly, what we do is, we want to make the process seamless as well. So having a good system, which is what we've seen, a lot of success, a lot of high levels of service and feedback from all of our partners, but also making sure that, that the technical component is also easy. So all of our releases of information, all our intake forms are all digitized and they're all on our website. So we really rely on Nicole and the outreach team to really get that information and train and inform all of you so you know how to seamlessly refer to us, but also look at ROI to make sure that it's in place. So last but not least, the kind of the difference of how we're looking at Ohio versus Kentucky. So in Ohio, we just have a different structure because of how case management is managed and how the service is built. So in Ohio, we have a series of what we call case management specialists, which represent regions in Ohio. But in Kentucky, what we're going to do is actually it'll be more simple, I think, and also I think higher level services. We're going to function that and put that into the targeted case manager. So in Ohio, there's no limit to what our case management specialists can do from a patient population. But in Kentucky, there is a limit, and so that all of the work that we do on the criminal justice site will not be regionalized. It will be managed at the site level. So a TCM or a series of TCMs at each site will be managing the reporting. I will be working with them to ensure that it's done appropriately and that they're supported. So I think that will be a really great kind of localized service in a way. So we really look forward to the opportunity to really engage in Kentucky and looking forward to your feedback. But you can certainly expect that we take the criminal justice relationship extremely serious. And we actually are probably already reporting. We're not tracking it in the company, but our official kind of go live date in Kentucky is May 17th. That's our next cycle of when reports will be built and sent out to all the folks. So if you're not receiving them now, you will receive them starting then, and then every 2 weeks, that process will repeat itself. So last thing is we use, our Teams channel is our preferred method of communication internally. In Ohio, at least, a lot of the counties, probation in the courts actually utilize Microsoft Teams. If you happen to use it, we can create a separate Teams channel, but this is where we have a specific channel to talk criminal justice and where all those relationships are. If you're covered under the ROI, oftentimes you can work with a site, TCM or outreach team and talk directly, and we can share information and reports directly. Otherwise, we usually send it through eFax as our alternative preferred method. So, but with that, again, super excited to be in Kentucky. We know there's a huge need, and we look forward to your questions and your feedback as well. Turn it back over.
Thanks, Nate. I want to say thank you for everything from everyone that spoke, and just appreciate all the work you've done to build the platform that you just spoke to. So there are many ways that Brightview supports our criminal justice and our local community partners. These are just a few ways that Brightview can help. We offer, of course, Dr. Kane spoke to targeted case management, which targeted case management, as we all know, is the glue that holds everything together. It's difficult to get better when your basic needs are not met. So we rely on our targeted case management a lot. We have reentry resources. We have multiple locations across Kentucky, so we can collaborate, care statewide. And then you'll just see here the outcome data that Nate spoke to. Next slide, please, Katie. So at Brightview, feedback is incredibly important to us. We have several methods of obtaining feedback from our patients and referral partners, which allow us to improve programs and services to meet the needs of the communities we serve. You can see here the importance of feedback and just example feedbacks and responses that we work to achieve. Next slide, Kate. So now we have come to the time where we will have, we're going to open the floor to everyone to address any questions that you may have. So I would like to ask that you please feel free to unmute your mic. You can chime in on any of these prompts. And to kickstart the conversation, I'm going to call on, hope he doesn't mind, Andy Sims, who is the Commonwealth Attorney for Jessamine and Garrett counties. Andy and I had several conversations about treatment, and maybe he has some questions to start us off today.
Yeah, maybe just a few, but I thank you, Nicole, for allowing me to be part of this. She asked me to just step in here and just give my perspective as being the head prosecutor here in this county and the county to the south of ours, Garrett County. So my job is to handle every felony prosecution in both these counties. And as we all know, virtually every case has its root in some sort of substance abuse. You know, the numbers say anywhere from 90 to 95, but I think it's bound to be more than that. And an example, we just had a grand jury this morning from about 9 to noon. That's why I was late jumping on here. And we indicted 30 cases. And of the 30 cases, virtually every one of them was either a possession of controlled substance case or a case involving a burglary in order to get money for drugs, a low-level trafficking case. We had a couple of assault cases where we're both the defendant and the victim were intoxicated. So the root of everything I do, or the root of every case I have, is substance abuse. So I'm excited to have a program like this, and it's been really good the last couple of years. There's been a drastic change in philosophy. Thankfully, in my circuit, I know there's a lot of prosecutors who still don't feel like I do. And there's, I think, even a couple of prosecutors here in our county that doesn't feel this way. But we all know that jail time is not a deterrent to drug use. And we all know it's an illness and it's a process, and we have to address the underlying issue in order to get them rehabilitated to reduce recidivism. I told Nicole the interesting thing about my caseload is, you know, there are a couple different ways of thinking as a prosecutor. There are some cases where retribution is the key. You know, I've got probably 10 or 12 pending murder cases, rape cases, assault cases, those type of serious cases where our goal in order to get justice for a victim is retribution and long sentences. Drug traffickers, you know, true drug traffickers also fall in that category. Not individuals who are selling drugs to support their habits, but individuals who are just, their business is drug trafficking. So those type of cases, we seek retribution. But the other ones, where this root is substance abuse, our goal is pure rehabilitation. And I'm thankful that my office thinks that way, and I'm really thankful that my circuit judge feels that way. He's very generous with probation. He gives multiple chances on probation. If somebody slips up in treatment, they're not automatically revoked. So we have a really good circuit. Now, I can't speak for our county attorney. They may have a different viewpoint on things, but I see rehabilitation as being the goal in virtually every one of these cases, because we keep seeing the same people over and over and over again. And I know why we keep seeing them is because we haven't addressed their underlying issue. So if y'all want my perspective on things, Nicole just asked me to pop in to answer any questions, on my end, but I really appreciate everything you all are doing.
Very much appreciate that, sir. Thank you for that commentary. Obviously, a lot of common ground for us to work from. Thank you for that.
Thank you, Andy. I appreciate that. One of the questions that I'm asked quite often is how do we treat methamphetamine use? Would one of you like to speak to that particular question?
Sure, I'll start off on that one, Nicole. So the good news is there actually are evidence-based and historically, meaning they've been around for years, good treatment for stimulant use disorder. There is not currently an FDA-approved medication, so the medical, psychological, and social component. There's not currently an FDA-approved medication, but we do have off-label medications that have some evidence behind them. And myself and several others are working on getting through a few medications that would be similar to what we have for opioid use disorder for methamphetamine use. We do know that contingency management, which is a strategy and a therapeutic intervention we use at Brightview, is very effective for methamphetamine use. We also know people tend to use more than one chemical, so alcohol and methamphetamines or methamphetamines and opioids. And so it gets a little complicated, and that's why it's important to have trained medical professionals looking at that particular piece and not just delivering part of the program, such as just social or just psychological or just medical interventions. So the good news is we're developing more and better treatments for methamphetamine use and other stimulants like cocaine, et cetera. We know that this is a rising issue, but it never really went away, to be honest. It just got overshadowed by opioids. So we're excited to continue to stay on the cutting edge, and I promise we will deliver the best treatment for stimulant use disorder that's possible as soon as it's possible.
Yeah, I'll just add on that notion of contingency management, the idea of reinforcing patients for engaging in treatment. There are limitations to how much you can do with that, but I think we certainly maximize that opportunity to do that in a compliant type of a way, to engage patients in treatment and reinforce the connection that they make with us and the ongoing connection that we make with them in that way. And we've continuously reinvented new ways to be able to offer a contingency management intervention as part of our program. And just earlier today, I was at one of our Kentucky centers talking about, hey, how do we take this idea to the next level? So we continue to press on how we translate that science to practice.
Thank you. Thanks so much. So I have just now looked at the time and we are at 1:01. So if no one would like to submit any other questions, if no one else has anything to speak to, in interest of being respectful of everyone's time today, we will wrap it up. So I'll give you a second if anyone wants to chime in on anything. Okay. So if there are no more questions, we're just going to leave you with some points and services on ways to access Brightview and ways that your clients and patients can access us to receive treatment. We've spoke to some of these already. In an effort to break down the barriers to care, one thing that we find here, the walk-in availability. When you're ready for treatment, you're ready for treatment. And we accept walk-ins. So that's fantastic. We have in-person and we have virtual care. We have made the commitment, as you heard earlier, to no wait lists. Our 24/7 access line is a real live human being that will pick up the phone. So we're really proud of that. And these are just some of the services that we offer. I want to thank you again for taking time out of your busy schedule to participate with us. I hope you've learned something valuable today. I have. And as a reminder, if you don't mind to stick your name over in the chat box, the name of your organization. And if you have any questions you would like us to follow up with, please place those there also. We're looking forward to working with all of you and to help better support your communities and help serve your communities. And we just want to thank you so much for being with us today. And I hope everyone has a great day and a great weekend. Thank you.
Thanks for joining us, everyone. Have a great day.
Thank you.